Good afternoon, everybody. I'm very pleased that we are privileged guests of the Foreign Ministry here, and perhaps we could see this as a signal that global health and health policy, international health policy, has an increasing significance in health diplomacy, or in global diplomacy and in foreign diplomacy. Let us take this as a sign and symbol. So I would like to welcome you all to this panel on the MENA region, which is entitled Fairness and Accountability, engaging in health systems in the Middle East and in North Africa. And if we are talking about this region, one must bear in mind that the MENA countries are experiencing profound transformations. And those transformations have been sparked by civilian demand and civilian movements. Therefore, governments, be it the old ones, be it new ones, draw their legitimacy not only from the process of election, but also from social and economic expectations. And so people who have said they want to have karama, they want to get liberal rights, political rights, but also social rights. The questions to be discussed here at this panel is with this background is on how to manage the high expectations on quick results while profound reforms in the health sector, but also beyond the health sector at the macroeconomic level, also in the overall governance and administrative system are needed, and also while responding to acute challenges such as the economic downturn or also the influx of refugees. So I would like to kick off this discussion. We have honorable members of the panel today here. I would like to kick off the discussion with the World Bank's brand new health strategy on health strategy, whose vision is to promote fairness and transparency and also accountability. So we would like to know from you, Anis Baris. I welcome Anis Baris here, the Director for Health, Nutrition and Population, Managing Director, and currently also acting Director for Human Development in the MENA region. I would like him, or ask him to outline, to show us, to inform us on overarching challenges and also on possible solution in those countries. Also, we know very well that every country has a specific situation. So, solutions have to be. You have to wait 2 seconds, 2 minutes, because I want to introduce also the other members of the panel. Solutions have to be homegrown. So we are very pleased to have His Excellency, the Minister from Jordan, Health Minister from Jordan here with us to give us the governmental perspective into this discussion. Thank you very much for coming and welcome here to this discussion. Then we have 2 people from the civil society, because as I have discussed, or as I have mentioned above, it was a civil movement. People want to move the change. We have 2 representatives from civil society organizations. We have first Ghassan Issa, who is chair of an interregional. Ghassan here on my left side. interregional NGO, can I say, the Arab Resource Collection. He will talk about this or tell you more about this. And we have Dr. Ala Shukrala from Egypt, who is also leading an NGO and will give his perspective from the civil society. And especially we want to know from them their vision of change. Then what is most needed currently, this is a bold vision in policy. But what we also need is to bring evidence into politics. So we are very pleased to have here with us very ambitious professor, Dr. Rache El Alouat from Morocco, who is chief of the Immunology and Virology Department at the National Institute of Hygiene, as well a member of the Academy of Science and Technology in Rabat. So welcome with me all these panel members.
I don't know.
Yeah, and then you should start off. Thank you very much, Enes.
Is it on now?
I have.
Okay, good. Okay. First of all, thank you, Susan, for organizing this session. I'm really very glad to be here and to be given this opportunity to make this presentation to you. As you know, at the World Bank, we are working in all regions of the world, in 6 regions in total. Middle East and North Africa region is one of those regions, but probably at this, you cannot hear me? The mic is on. It is.
Maybe you have to be closer.
Cool. Like this? Okay. Okay, I'll try. I'll bend over. Okay. As I was saying, at the World Bank, we have 6 different regions, and Middle East and North Africa region is one of the regions where we are very active. But I guess that in our current times, this is the region which is going through some major social, political, and economic changes. Given the situation in the region, we have really upped our engagement in the countries of the Middle East region, and we are working across 19 different sectors, health, nutrition, population being just one of them. I represent here the HNP, which we call Health, Nutrition, and Population in the bank. And as the HNP team, we prepared a new strategy, a new engagement strategy for the Middle East region. So I will be sharing this strategy with you. And we will be very pleased to have your comments, even though I must admit that during the preparation of this strategy, we have consulted quite extensively with civil societies in the region of MENA. When we say MENA, I will explain it to you. Obviously, it includes North Africa as well. So, is it still not on? Okay, yeah. Okay, sorry. So, obviously, a strategy should be a live document, and we are always open to have more suggestions on that. So let me, without any further ado, let me go ahead and present the strategy to you. Okay. The strategy is called Fairness and Accountability, Engaging in Health Systems in the Middle East and North Africa. We choose this title particularly focusing on a fairness and effective accountability for the following reasons. First, in this presentation, I will be actually trying to address 4 different questions. The first one is, I have already started doing so, but I will provide you with some data. Why is the World Bank developing health strategy for MENA? How can MENA health systems be made more fair and accountable? What World Bank products contribute to improving fairness and accountability, and what is the process of implementation? Even though it is a rather long preset presentation, I will mostly be focusing on number 1 and 2, so the questions of why and how we are doing that. Okay. So why is the World Bank developing a strategy? This is the region. All the countries in yellow are the countries of the MENA region as defined by the World Bank. Now, if you look at the region, this is a region which is not homogeneous, unlike some people think. We have 20 countries, about 350 million people, 85 million of these people are living in middle-income countries, 8% of them in high-income countries, which are basically GCC, which is Gulf Cooperation countries, which are highlighted here in purple. Then we have 7% of the population live in low-income countries, which is basically Yemen and Djibouti. But this is a region, as I started at the beginning of my presentation, going through turbulent times. There have been a number of governments overthrown. These countries are highlighted in dark blue or black. Then a number of countries, we have civil war. There are protests and governmental changes in some of those. So when you look at the whole picture, you will see that there aren't really any countries in our region which are totally stable, even though some of them may give you that indication. But in addition to these social and political changes, there are a number of things that we have to keep in mind. First of all, the government debt as a percentage of GDP in most of our countries is increasing. This has especially been the case since the beginning of what is called the Arab Spring or Arab Awakening. International reserves are going down. This is to give you a big picture, macro picture. And unemployment in our region is very high, especially among the youth and especially among the educated people, which is actually one of the factors that explain the discontent of the people whom you have seen on TVs in Tahrir Square and in Tunisia. Now, if you ask the people of the Middle East what are the problems that of highest priority, they will identify education and healthcare. Just a word on the education. This is especially the case even though there is a very high percentage of people in our region who are well educated, many of them having university graduates. There is a big mismatch between what people learn at schools, what kind of skill set they have, what actually the market, the market requires. And if you ask people, as we have done during the preparation of strategy, what do they think about the health system? These are some of the quotes coming from the people. The one that I like the most is said by one woman in Egypt. She basically summed it up quite well. She said, a public hospital is where you lose your life, a private is where you lose your money. Obviously, we should not be generalizing things. There are still very good hospitals in Egypt. There are very good hospitals in Jordan. There are very good hospitals in Lebanon too. But if you look at it, you will find that in many public hospitals, because of the lack of investment over the years, that there has been a gradual decrease in the quality of care. There are many reasons for that, but I don't want to go into too much detail. But I think it sums quite well, especially based on my own recent trips to the region. Now, what are the current challenges? Let's start starting with that quote. First of all, in terms of health status, there is quite a significant change, a shift in the burden of disease. We have less and less communicable diseases and more non-communicable diseases. It is going up, so that means that we will have to adjust health systems to this changing burden of disease. Now, if you look at the population, as I said, we have about 355 million people in the region, but it will almost double by the year 2050. And most of these people, more than half actually, will be adults at productive years of their lives, 25 to 64. And it is our responsibility to make sure that these people who are young right now will start their productive life as healthy adults. But also, if you look at the inequalities in the region, you will realize that there are major inequalities between the rural and the urban, within the countries, across the countries, between the poor and the rich. This graph simply shows what is the inequality ratio for a number of health outcomes and health services that, for example, just to give you an example, in a country like Libya, which is high income, it is a child born to a disadvantaged family is 6 times more likely to die during the first years of life than a child who is born in a better to the family. And there are many examples like that that we can cite in the region to simply say that inequality is a major problem. In addition to that, we still have a big problem with what we call the double burden of malnutrition. On one hand, we have children who are malnourished, stunted. On the other hand, we have ever-increasing obesity among the children, but also among adults. Especially, this is the case for women. Now, if you look at the financial protection, what is the situation? In our region, in general, you will see the countries of our region, that the public expenditures on healthcare is quite low. And because of that, out-of-pocket expenditures, these are expenditures that people pay out of pocket at the point of service. This doesn't include prepayments like insurance premiums, for example. In our region, is very high. Actually, in some of our countries, whether it's Morocco or Egypt or Iran or Yemen, it is 50, 60, 70% of total health expenditures are out of pocket, paid by people. Obviously, you could imagine the impoverishing effect of such private payments. If you look at the responsiveness, the third goal of any health system is to improve responsiveness. It is quite unlikely that we could do so in our region because of the current input status, whether it is in terms of the number of hospital beds, whether in terms of the physicians, or whether in terms of the nurses and midwives. Overall, in short, again, with some risk of generalization, there are countries, exception like Lebanon, for example, where we have a quite good number of physicians and not so much for nurses, but hospitals, beds, etc. Jordan also being a bit of an exception. But in most of our countries, compared with OECD countries, you'll find less number of physicians per 1,000 population, less number of hospital beds, less number of nurses and midwives. And in addition to that, there is a major distributional problem. Most of the physicians being specialists living in big cities. You go to Morocco, you will find them in Rabat and Casablanca, but not necessarily in poorer regions. Okay. So, let me just share with you a couple of words from some of the people that we interviewed while we were preparing this.
ضعف الخدمات الصحية اللي يوفرها للمواطن، فما فرق كبير ياسر مثلا بين القطاع الخاص الكلينيك والقطاع العام.
هو هنا ما فيش خدمات صحية وعلاجية للشعب المصري اللي هو الفقير. هنا اللي معاه فلوس بيصرف، بيروح مستشفيات خاصة ويروح بره ويسافر هنا، لكن الفقير ما بيخش علاجات خالص.
So, the question then that arises from this very rapid diagnostics is that how we can really make MENA health systems more fair and accountable. Fair in terms of the health outcomes, obviously fair in terms of responsiveness, first in terms of the financial protection. As I said, the three goals of any health system. But also accountable. Why we picked up this word accountability in addition to fairness? Fairness, you will see from the health research, is basically close to what we call equity. But in terms of accountability is because most of our systems are such that they do not seem to be accountable to the people, right? They are represented by the government officials. The pluralism is not necessarily there. This is one of the reasons why I picked this. So, here is the core of our strategy. We call it fairness and accountability built on sustainability. For fairness, there is a bit of a problem here with the screen. It doesn't show what we have on the sides, but let me do this. Okay. Here, what we mean by fairness. Fairness in healthcare means basically the absence of systematic disparities, the just distribution of burden of cost, and the equitable and timely response for health needs. This is how we define it for the strategy. And then it has two elements. One is health status. Let me go quickly here because of time. The second one is financial protection. And the third one is responsiveness. Okay. Then we go to accountability, which also has three dimensions. We go quickly. What it means to have the health system more accountable is basically referring to demonstrating and taking responsibility for performance to create high-performing systems. It encompasses respect for rules, regulations and performance standards, and includes grievance redress mechanism, all the things that we have less in our region. And it has also three dimensions. One is accountability to the population, something that we will have to work a lot. Then accountability of the payers, those who pay for health services. And then accountability of the providers, those who provide the services. Okay. And finally, all this has to rest on sustainability. which is basically the capacity of any government of health system to finance in the future its expenditure programs in such a way that it will not compromise service coverage and quality, nor the availability of the funding for future generations. Okay. So, the focus is then on fairness and accountability of the health systems, right? So how we could, as the World Bank, improve these two guiding principles of the health systems. I'm sorry, something happened here. I'm really sorry for that. I don't know why it... Okay, just a sec, please.
Perhaps without presentation, Enis?
Sorry?
Without presentation, what you can do, World Bank?
Okay, I think yeah, just a second, I'm coming here. Yeah. Okay. Yes, sorry for this mishap. How could we do that in the bank? Basically, if you look at what is happening in the region, in terms of the disease burden, non-communicable diseases, some emergent infectious diseases, like in the countries in Yemen, for example, and also Djibouti. I talk about the malnutrition, early childhood development being a major problem. Maternal and child health, especially MDG 4 and 5 agenda, is still being very much with us in many of our countries. These are the kind of health status-related problems that we have. In addition to that, we have a major problem in terms of the population coverage. We don't have universal health insurance in many of our countries. The coverage, especially through public funding, is still low. We have provider payment systems, which are basically, most of our countries are salary-based, therefore not conducive to giving people incentives to be more productive, to be more performing, and to be more accountable for the nature of the services they provide. And on the other hand, on the governance side, we don't necessarily have the separation of different roles and responsibilities, governments often being the financier, the payer, the oversight agency, the steward, the governor, but also the service deliverer at the same time. So when you combine all these functions under one roof, obviously you have potential problems of collision, potential problems of basically not accountable for what you are providing. Then at the beginning of my presentation, I also mentioned the fiscal space issue that we have. In many of our countries, as I said at the beginning, there is a major problem with the budget because these countries often depend on tourism, on oil revenues, on remittances, and what happens at the end, that when these revenues fall down as a result of the political turmoil, etc., then there is very little space for fiscality, meaning that there is not enough money for the health system. And also the quality of care, I mentioned that as a problem. So when we look at these problems, actually these are very much the areas that we as the World Bank are working quite a lot. And we have a lot of experience and expertise from many other countries. This is global experience, obviously, on one hand. Second, of working multi-sectorally across different sectors, health, education, obviously macroeconomics being some of them. The technical expertise, having done similar work in other regions as well, and also more and more, I will not get into details too much, on the diverse financial products that we have. Okay. So how we are going to implement this, this strategy? First, as I said, we have technical products and the financial products. On one hand, we have lending opportunities, obviously, but on the other hand, we have also technical products, whether these are policy notes, sector reviews. Then we have a monitoring framework, a results framework that we have developed, which will measure the progress that we will be making in each of the countries that we will be actively engaged in, but also across the region, meaning that we will follow up and gauge the metrics that we have developed in order to, in order to monitor the progress in each of these countries. And finally, this time, we will be working differently. That means that, as you know, the World Bank mostly works with client countries, with the governments, but in this case, we have already reached out to academia, to NGOs, to private sector, to civil society, and other development partners as well, in addition to governments. Okay. So, This is what we are doing in the short term. We are trying to understand better how we can develop what we call the country engagement strategy for each one of the clients. We have a strategy document. It is on our website. I will show you the link at the end of my presentation, where you can read in detail what the strategy entails. But then you take this strategy, you go to each one of the countries, and you develop what we call country engagement strategies for each one of them. And this is a process that we have already started. Then we will develop with them what we call the client's tailored solutions, and we will start implementing, monitoring, and managing the strategy from the beginning of, or mid-June, June 2014 to June 2018. We have already started it. The first launch started in Tunisia. We had a media launch in Morocco, and we had a symposium in Marseille as well, where we explained to mostly our European colleagues. Then we have this launch for the Mashreq countries in next week, actually. And then we will have another one for the GCC countries, Gulf Cooperation Council countries. Let me finish my presentation by some words from our president, Dr. Jim Kim, the words that the presentation he made at the World Health Assembly in Geneva in May. He said that to free the world from absolute poverty by 2030, which is now the current World Bank strategy, not health in general, is actually to eliminate absolute poverty by the year 2030, and also to boost what is called the shared prosperity. We must ensure that all of the citizens have access to quality and affordable health services. We can do that much more. We can bend the arc of history to ensure that everyone in the world has access to affordable quality health services in a generation. Together, let's build equity and economic transformation as one single structure. So not just economic transformation, but equity as well, a citadel to shelter human future. Now it is the time to act. Thank you. And you can find the strategy at this web link. Thank you very much.
Thank you very much, Enis, and sorry that I have chased you so quickly through your presentation. We will have the opportunity to ask questions and to discuss this presentation. But what I have recognized is this shift of paradigm within the World Bank, acknowledging finally that there is a responsibility of the state, of the government, to deliver and to invest into institutions. And I think this is very interesting. Perhaps that your new director is coming from World Health Organization? So I don't know. So I would like to ask somebody who is the main actor. So it's not the World Bank is doing a strategy and supporting the countries, but the main actors are the governments. So I would like to invite you, Excellency, to give us your perspective on the priorities in your country. Thank you very much.
Okay. Excellencies, distinguished guests, ladies and gentlemen, it gives me great pleasure to be among you today to take part in this prestigious event and to shed light on the Jordanian health sector, achievements, challenges, and the impact of the Syrian refugees on the health system. In Jordan, the Ministry of Health is the competent authority which undertakes all health affairs and issues to maintain health facilities and services by providing preventative, therapeutic health services at the public and private health sector. As of the early 1980s, all national socio-economic plans have stressed on the right for access to health and health care, and all Jordanians today are provided with health insurance coverage within the available means. Ladies and gentlemen, despite the hard conditions Jordan faced during the last 6 decades, great achievements have taken place in the health field. Jordan achieved universal child immunization in 1988 and made considerable progress in reducing the major health risks for infants and children. Jordan has become polio-free since 1995. It has also marked drastic declines in death rates as well as shifting the composition of illness away from infectious diseases to non-communicable diseases. Jordan's health system is a complex amalgam of 3 major sectors: public, private, and donors. During the last decade, the health system was reviewed and reformed, addressing the following areas: supporting and strengthening primary health care, improving managerial, technical, and professional performance in public health sector, enhancing partnership between the public and private sectors, implementing a national health insurance system, improving healthcare financing, and promoting medical tourism. Due to our commitment to make all health services available and accessible to all, the Ministry of Health exerted great efforts to utilize the public and private health providers and to improve the quality of health services by implementing the National Health Services Accreditation Program. Ladies and gentlemen, comprehensive health care coverage is a major priority to the Jordanian health system. Therefore, the government adopted many measures during the last decade to improve quality and reduce inequalities among population groups, exemplified in the following forms. All government employees are covered by the civil health insurance system. The husbands and children of the female government employees are included in the insurance system. Other vulnerable population groups are covered by the insurance system. For example, people living in poverty pockets areas, pregnant women during pregnancy and postpartum, children under 6 years old, around 450,000 children, elderly citizens over 60 years can willingly join the civil health insurance system. The government bears 50% of the value of their subscription. Migrants, including workers, are being treated at Ministry of Health hospitals and health centers at subsidized prices compared to the prices at the private health sector. In some cases, the Royal Court clinics, sponsored by the Jordanian government, refer uninsured patients who cannot afford catastrophic treatment costs to public hospitals, and the government reimburses hospitals for the full costs of these referrals. The Ministry of Health, in its quest to reach universal health coverage, developed a national health strategy which aims to increase the percentage of the population covered by the civil health insurance system to 47% in 2017. Services under the health insurance system will be reviewed periodically based on the available resources and financial sustainability. Ladies and gentlemen, when mentioning equity and equality in health service provision, I find it difficult to continue without mentioning a real challenge facing not only the provision of the essential healthcare services in Jordan, but also many other necessary services. Jordan today faces two main challenges that need the active support of its European partners as well as its partners of the international community. Firstly, as you all know, the world economy has faced a number of challenges ever since the economic crisis in 2008. The economic crisis, coupled with the political disturbances in the region, have had their toll on the Jordanian commerce and economy to a great extent, and therefore presents a challenge for it to provide the basic needs of its people. Secondly, and perhaps more importantly, the great increase of the population of about 20% in Jordan in the past 2 years due to the refugee crisis. Around 1.5 million Syrian refugees alone, in addition to the Palestinian refugees and refugees from other countries like Iraq and Libya, and has put a strain on Jordan's already limited resources and affected the ability and the quality of the basic services. Most important of which being the health services to Jordan's citizens and guests, given the limited means. Allow me to brief you on the Syrian crisis and its impact on our health sector. Despite its own socio-economic challenges, Jordan continues to adhere to an open door policy and provided essential services to all Syrians fleeing the violence. However, this massive influx is severely straining the country's limited economic and social resources. While health services are readily available to Syrians living in refugee camps, almost 70% of all Syrians in Jordan live in urban communities, placing a significant burden on the country's health system. Although there is enormous pressure on Jordan's health system, there has been insufficient investment of resources by the international community, resulting in shortages in hospital beds, nursing staff, and chronic diseases medicines. Jordan's public health system is dangerously overstretched, and lack of funding for health sector poses increasingly grave risks to health status and social stability. Jordan needs now and in the coming years significant support in the form of burden sharing from the donor community to sustain its health services for Jordanians and Syrians displaced community. Therefore, I take the opportunity from this important pedestal to first of all thank Germany and our other European friends and partners for all the support they have given to Jordan so far on the refugee issue through direct aid or projects, but also stress out that more is needed to allow Jordan to go ahead and out of this crisis with the ability to provide the best health service and other basic services possible to its guests and citizens without further jeopardizing and stressing its resources. Finally, I wish to extend my sincere gratitude for you all and the organizers of this important event, and wish you successful and fruitful deliberations and all the best. Thank you.
Thank you very much, Excellency, for this impressive report on what you already have achieved with regard towards universal coverage. And I think it became also very clear that a country with about 6 million inhabitants is really overwhelmed with this specific situation on giving dignity and also coverage to refugees coming from the region. Thank you very much. We will have the possibility to discuss this further. So in order to really get this opportunity for discussion, I would like to ask the following presenters or panel members to do short presentations. So now we are giving the floor to the civil society, and please go ahead, Ala.
Well, I promise to do my best, but I have to start by saying that I'm very happy to be here, as I have my heart really split between Germany and Egypt. I lived many years here, and my family is here. And if I had known that I'm coming only before 2 days, they would have been with me. They are in Cologne now. So, just to start, sorry that I took time in that. Right, but I guess my work now is needed very much in Egypt, and that's why I'm there. I really want to talk about health change, but change now, I think, as you can see in the region, is very much related to a revolutionary change and the role of civil society in that change in the past, in the present, and hopefully in the future. One thing that crisis in the healthcare, in health and in the healthcare system, and I'm very happy that Dr. Enis started by giving the example of the Egyptian woman who was saying to go to a public hospital in Egypt is to lose your life, and to go to a private one is to lose your money. We also say if you go to a surgeon, you count your fingers when you come out. If it's a private surgeon, maybe has taken one off. Anyway, but the crisis in the healthcare system, what I want to stress here is really which has been for the last 20, 30 years talked about very strongly, as I will show, and as our colleague has shown, is not only in health. And as Vincent Navarro says, it's actually a realization of the societal crisis which led to the revolution of 2011 and which is continuing till now in Egypt and in the MENA region. And I think it has far-reaching effects all over the world. And I claim that it is the result of a socio-economic system that led to the crisis in the healthcare system as in other systems. What I wanted to cover, all right, why is the revolution? Why did it happen? Where are we now? And here I claim, as I said, that the crisis in the healthcare system is but an example of the societal crisis which led to the revolution. And then what is the role of civil society before and during the revolution? And I think that the main, if I want to if somebody asks what is the real underlying cause for the rebellion that took place in Egypt and in the MENA region, there are many immediate factors, there are intermediate factors, but I would say it is the social trap. It is not that there are poor people, it is not that people are getting richer or poorer, but it's when people feel trapped in the sector they are born in, that there is no hope and particularly when the youth feel that there is no future, there is no hope, because the socio-economic system is moving to trapping them into what they are born through the decay of education, of health, and of other sectors, as my colleague talked. This is I was working with the WHO on the social determinants of health, and this is just to show that this social trap is really related to the socioeconomic policies which led to increased inequities to an unprecedented extent. Like, this is just a slum, one of the slum areas in Cairo, which now there is something like about 1,330 slums all over Egypt. This is an uneven, supposed to be an underestimation. It shows on one side the fringes of the Ezba, the slum area, which goes to Nasser city and reaching the WHO, very affluent area, and then just beside it, the Haggana, which is a poor area containing about 1,200,000 people. In this, this is in one of the studies that took place. These are some of the factors that people declared that are pressing: cost of health care, and particularly inaffordability of catastrophic illnesses, where the most abuse and corruption in the private sector as well as the public sector, neglect and bad treatment, as well as shortage of drugs in the public sector. However, the inequities in health, as in other sectors, and the decay that was taking place moved to a struggle for health. And I think that was a very important thing that took place during the decade before the revolution. 2005, a campaign started against the infringement on the right to health by a new insurance law, which, by the way, was supported and by the World Bank. Actually was heading it with the International Monetary Fund back. So I'm very happy to hear about the changes in the World Bank policies, and I do hope that we can actually dialogue with each other to see where can we move from here. The campaign utilized media, mass rallies, and pickets, and actually in 2007 it was able to stop the law from being passed through using the court, and it stopped it from being passed in parliament. And of course, when the revolution took place, the law was frozen, and there is a lot of positive changes that is taking place in the law today, and we hope that with the cooperation with the new strategy of the World Bank, that if inequities are to be addressed, then we have to radically look at the law. This is also during the social determinants of health. These were two women that were found suffering from a brain tumor living in this area, which was a high voltage area. And I use here the quotation from the head of the social determinants of health at WHO, and he said, "What good does it do to treat people's illnesses then send them back to the conditions that made them sick?" And here, I think you are seeing this a lot. This was Tahrir Square during January 2011, when the revolution started. And here I just want to stress, when I want to move to civil society and the revolution. What took place in 2011 was a social revolution. It was a revolution among all sectors of society, particularly the poor. However, civil society and the youth were the vanguard of this rebellion. And here, when I talk about civil society, I'm talking about two trends within civil society: the human right-oriented trend and the conservative, discriminating, and despotic trend, which is political Islam. However, during the first course, especially what I call the 18 utopian days that we lived in 2011 in Tahrir Square, it was the civil society, human rights discourse and action which governed the scene. Non-discriminatory, equity, equality between men and women, between all people existed there, and as I said, a kind of utopia. And here is a picture to show that we were all there, women, men, etc. So the stereotype that the Arabs are all backward and they are despotic and their women are all pushed back. No, this is not true. This is what the revolution wanted, but there are other forces that are fighting against that. This is a picture of 2012, and this shows just the struggle is continuing, and this was during the time where the Muslim Brotherhood took power, and these were the people against that. Of course, as you know, that around 2012, the Muslim Brotherhood or political Islam became in power, and there was a tense alliance between them and the army and the police. There was an attack against all the core institutions of the state to attempt total hegemony. There is an attack against civil society, then the media, yet resistance increased, and the biggest uprising took place in 2012. Then, I don't know if you've heard, and this is again civil society, where the youth played the role in the what is so-called the rebel movement, where they started taking people's signatures to change Morsi or to overthrow, oust Morsi, the head of the representative of the Muslim Brotherhood. Here is people signing the paper with their ID cards and not fearing reprisals, women, men, and everybody. And here is another picture of the millions that went in June, the 30th of June 2013, to rebel against the power of the Muslim Brotherhood. So when here in the West there is a lot of talk about the counter-revolution or the army coup d'etat, I think we have to be cautious when we use such terms and how true it is. I think the army succumbed to the people's pressures and to civil society, and not that it took power for itself. In fact, there was an alliance between the Muslim Brotherhood and the army as a counter-revolutionary, so it was not that a coup d'etat. Demanding, here is again another picture of Tahrir. And this is a picture of the doctors, Egyptian doctors in the squares. And here is but the doctors also rebel against injustice. And here I just want to add one thing about the decaying healthcare system. Why is the public sector so badly, and why is the private sector also, on the other hand, corrupt and so on? I think one of the reasons we have to look at, and not only is the orientation, but also the incentives of the doctors. A doctor which doesn't take more than 100 euros a month, I think does not give very much to the patients also. So the injustice to the health team is among the most important factors that have to be addressed. Now, what is the future role of civil society? I'll end up with that because that's the point. I think we have to focus in democratic and social demands and alternatives. We have to provide clear alternatives that are doable, and even though they can be far-reaching. In the healthcare, we have to combine the struggle of the health team for a better and dignified life with the alternative models of primary health care with quality and universal coverage and accountability. And in this, I really would like to put under primary health care, many underline it several times, because it's not going back to Alma-Ata, but no, it's moving forward, and it should be based on empowering local communities to be the real governance of their areas and of the healthcare system. Engaging local communities is the true engagement of, and empowering them is a true engagement of society in deciding their priorities and the areas where they. The last one, I think we have to improve regional and international dialogue for alternatives and build on the themes that the revolution in the MENA region called for: democracy, social justice, and dignity. A better world is possible. We lived in it, and we will see it together. And the last thing is this one. I wanted just to show this is a child in the same very poor slum area, and this is a piece of a poem. Many things die in the winter evenings, but many others refuse to die. They refuse to die, and we have to stand with them. Thank you.
Thank you very much, Ala. Health is a right, yes, and masses of people have fighted for this. So, what are then the ways to get it and to bring it into reality? You have thank you very much, Ghassan Issa. You have more the regional aspect from the Arab Resource Collective.
Thank you very much for this opportunity. I will take it from where Dr. Ala ended and try to translate that into a regional perspective. I agree fully with what Dr. Ala said. First, I would start by saying that if we want to talk about the MENA region, I would rather talk about Arab countries. And because of the political aspect of the term MENA region, I would say Arab countries. It's not MENA region. So Arab countries are not homogeneous. They are different. And whenever we want to formulate a strategy, health strategy or any other strategy for the region or for the Arab countries, we have to take these differences into consideration. For instance, I would rather use the percent of governmental expenditure on health rather than any other indicator, because the governments are responsible, and how much they pay on a certain sector is very important to say how they are dealing with this problem. For instance, percent of governmental expenditure on health varies in Arab countries from 4.3% in Yemen to the highest of 17.6% in Jordan, for instance. In education, it varies between 2.75% in Sudan to 25.7% in Morocco. And here I would introduce another expenditure, which is the military expenditure. In Tunisia, it is 5.1%, and in Sudan, it's 53% of the budget. And these are the differences that we should look at. Now, all these percentages will not give a good implication of what's going on unless we go to the budget itself and the population. And we have to compare that accordingly. In the revenue of Saudi Arabia and its budget, it's $326.5 billion, whereas it is $4 billion in Sudan. And in population, in Kuwait, it is 2.7 million people, whereas it's 82.5 million people in Egypt. So these are the differences that we are dealing with, and we have to look at these differences. Now, to come to another point, which is the health challenges in this area or in these countries. And we have two types of health challenges. We have the chronic problems, the crisis, the health crisis in Arab countries that's accumulating, and we have the new emergencies that are building up after the Arab revolutions. So I will mention some of these challenges. One is health is considered as an investment in the Arab country, mainly in the Arab countries, not as a human right. And here there is the predominance of the private sector, the predominance of the curative side of medicine rather than the preventive, of course, not to mention the social medicine at all. The second one are chronic problems with the health services, whether it is qualitative or quantitative. And most of the Arab countries lack a national health policy, for instance. And there is unequal distribution of services between cities and the urban and the rural areas, of course. For instance, in Lebanon, we have a very high ratio of doctors to population, but their distribution is very unequilibrium. To come to type of diseases, for instance, we have a degrees in non-communicable diseases in the Gulf area, for instance, obesity and cardiac things, whereas infections and malnutrition is predominant in other countries like Yemen. And nowadays, we got, for instance, again, infectious diseases. We have 2 cases of poliomyelitis that emerged in the south of Syria, and this will be very dangerous for Jordan and Iraq, I think. And of course, new emerging health problems are dying by bombing, which is almost everyday practice in Syria and Iraq and Yemen, for instance. Now, and as the concept paper of this session that was distributed, one outcome of the Arab awakening revolutions that started in December 2010, which called for bread, freedom, and social justice, and improved accountability, was rising demand for a better delivery of health services. Right, this is very true, but if you go to the slogan of the Arab revolutions, which is bread, freedom, and social justice, people in the streets address the problem in a very holistic and integrated approach. And when we want to deal with strategies, we need to be, as much as the people in the streets, to be holistic and integrated in our strategies. So accordingly, I would suggest to have a framework to address these challenges. A framework that depends on 2 elements. First, the healthcare determinants of health, which are factors that can be addressed by the healthcare system. And the second one, and the second element of this framework are the social and economical determinants, which are social and economical conditions that influence health. I would say that the World Bank HNP approach, although important, will address mainly the healthcare determinants, but it will not tackle the social determinants of health. In 2008, the WHO Commission on Social Determinants of Health issued a report called Closing the Gap in a Generation. And I quote from that report, "Unequal distribution of health damaging experiences is not in any sense a natural phenomenon, but is a result of the toxic combination of poor social policies and programs, unfair economic arrangements, and bad policies. Social injustice is killing people on grand scale," and I unquote. The report listed these social determinants in 3 main titles: daily living conditions, equity from the start, healthy places, healthy people, fair employment, decent work, social protection across the life course, universal health care and not universal health insurance. Then the second title was Power, Money, and Resources, talking about health equity in all policies, fair financing, market responsibilities, gender equity, political empowerment, and then knowledge, monitoring, and skills, which deals with monitoring, evaluation, impact assessment, and research. And then again, the World Conference on Social Determinants of Health in Brazil in 2011 aimed to catalyze coordinated global action in 5 main areas. 1, tackling the root causes of health inequities, that is the causes of causes. 2nd, the role of the health sector. 3rd, the promoting participation, and this is very important, empowering communities. 3rd, global action on social determinants. And 5th, monitoring progress. In a simple way of looking at this matter is, if we take the indicator of child mortality rate under 5 years. In Gaza, Palestine, the child mortality rate under 5 years is 20 in 1,000. The question will be, what are we doing for the 980 survivals of this 1,000? And then again, the statement on health in all policies from in 1910 from Adelaide in South Australia. It is moving toward a shared governance for health and well-being together. It's not separated. Taking account of health means more effective government. More effective government means improved health. Okay, having said all that, I would suggest that the World Health Summit, WHO, the World Bank, formulate or adopt a formula, a model, a package for the Arab countries that will take all the above into consideration and which can be tailored according priorities to each country needs. A model which will have the following stakeholders, namely governments, communities, academia, civil society, and international agencies, and will have the following major titles. First, a determinant approach to health, determinants approach to health, that is healthcare determinants, the healthcare determinants, and here it can include health in all policies, national health policies, and others. The second is community participation, innovative approaches, as the civil society is not should not replace governments in its responsibility for health. It should work on models. It should be holistic, integrated, and inclusive models, and it should work on monitoring, evaluation, and governance in general. Okay, and the third one is governance, monitoring, and evaluation. These three elements, I think, can be tailored according to the needs of each Arab country, and they address the challenges in a holistic, integrated approach, as it was declared by the Arab people in the streets starting 2010. By such model, by implementing social justice, and social justice here I mean the concept of rights, the balanced distribution of wealth, and equal opportunities for all. These three are what we need. That were elicited by here I should say that the challenges that were elicited by failure of the social contract between the Arab people and their regimes, politically, economically, and socially, could be faced because health is a marker of how well policies meet human and social needs. Thank you.
Thank you very much. It has become very clear that social justice is one very important issue, and that in order to improve health system or health situation, there have to be more around the table than only health ministers, also other ministers, and especially also the civil society to drive the change. Thank you very much. And now we have a very competent lady who did not have the opportunity to speak so long. It's last but not least, the academic view. What we need now are wise and visionary policies, but they should be based on evidence. So what is the evidence on what should be done now, on priorities? Thank you very much.
Thank you. I would like first to thank the organizing committee of the World Health Summit for inviting me. It's a privilege for me to be a part of this debate on health reform in the MENA region, bringing the academic point of view. Before moving to the health policy and management area, I'm from the health research sector and use it to participate to health programs, development and evaluation in my country for almost 25 years, especially during the period when I was in charge of the National Public Health Institute in Morocco. My contribution will focus on two levels, a political level and institutional and organizational level, and I will address gaps and potential solutions. At political level, due to the lack of coordination and joint action with other departments, local health departments do not manage to achieve sustainable positive results or scale up several health initiatives and programs in the MENA region, even if interministerial committees and/or local committees exist. In fact, nearly all social determinants of health are outside the direct control of the health sector, which make intersectorial collaboration crucial to reach better health and reduce health inequities. From my point of view and the academic point of view, where we have addressed that adoption of health in all policies approach as a legal framework in the MENA region countries is one way to make it happen. In fact, health in all policies approach will help to institutionalize and strengthen the existing intersectorial health-related program, as well as develop new health intervention and policies involving different stakeholders, among which government non-health sectors, private sectors, citizens, and communities. The second priority issues at the political level relates to moving to a public health-oriented approach in order to guarantee efficient disease prevention and control, ensure relevant health promotion, and deliver primary health care in rural and underserved areas. Most health services in the MENA region are based on a curative model that is becoming increasingly expensive to maintain and ineffective to address emerging health challenges. While many traditional public health services are well established in the MENA region, some public health functions, such as intersectorial policymaking, public health information and education, health status monitoring and evaluation, remain underdeveloped. The MENA region has several universities and programs providing public health training. However, only few of them are well equipped to answer the upcoming public health challenges and opportunities, especially non-communicable diseases and climate change. So how to make it happen? Firstly, establish a public health law when it doesn't exist, in order to clarify the public health objectives and impact on the political agenda, as well as to facilitate planning and coordination of public health interventions by the government and its partners. Secondly, reconfigure health service delivery to integrate the provision of preventive and promotion services. Thirdly, establish independent and science-based public health institutes in the MENA region countries in order to ensure comprehensive epidemiological surveillance system and reliable health system status monitoring and evaluation. Fourthly, strengthen and upgrade public health education curricula and training to meet international standards and build a capable and sufficient workforce. At institutional and organizational level, I'm considering, and it's not a surprise, knowing my background and experience, that promoting research and knowledge generation, dissemination and translation based on efficient health management and information system is crucial to craft the appropriate health reform from the MENA region countries. Health research is weakly implemented in the region because of poor governance, lack of capable human resources and RID funding, as well as insufficient ethics compliance. Moreover, there are very few well-trained policymaking and public health communities, research communities that focus on implementation research and evidence-based decision-making. Finally, the little research that is conducted in the MENA region is more focused on clinical research than on health policies and system research or health promotion. To promote research and knowledge generation, dissemination, and translation, in order to ensure health sound policies and intervention will require to target strategic functions. First of all, organize and coordinate health research at a national level in order to ensure proper research stewardship via clear roles and responsibilities for health research institutions, a relevant health research priority setting process, and long-term effective partnership. Secondly, reinforce individual and institutional health research capabilities with an objective to better serve sound policies and intervention. This will require a multidisciplinary capacity building approach based on context, on country context and priorities. Thirdly, build a regional knowledge management platform to translate and share local, regional, and global health research funding and lessons learned that can empower nations in the MENA region to craft their own solutions. A global health research network for the MENA region aimed to improve the health of the population, to reduce infectious and non-communicable diseases and related risk factors, and to achieve MDG's health-related goals by enhancing health system performance through using linkage and exchange and knowledge management platform to move research to policy will help to answer these questions. This global health research network will integrate multidisciplinary and multi-sectorial evidence-based approach to inform policy while focusing on networking, partnership, knowledge transfer, and the training of public health workforce. Such a network will focus on local and regional issues and reach out to regional partners to build research and knowledge management portals, sharing resources and lessons learned, and addressing regional issues that are beyond national borders. The Global Health Research Network for the MENA region could be designed in order to address the three above-mentioned strategic functions, namely the stewardship function, the empowerment function, and the knowledge management function. As the quality of research and knowledge generation, dissemination, and translation relies closely on a well-functioning health management and information system, and considering that disease surveillance systems are mostly inadequate in the MENA region, with insufficient commitment to the systems, lack of practical guidelines, overwhelming reporting requirements, weak involvement of the private sector, lack of transparency, shortage of human resources, and poor data analysis, it is urgent to put in place a health management and information system in the MENA region countries in a cost-effective and comprehensive way while taking advantage of the new information and communication technology in order to help with technical support for the epidemiological surveillance, care and cost assessment, as well as determinant of health system performance, health status, and impact evaluation. Such well-defined and functioning information system will help to guide improvement efforts and promote the development of a learning health system. I hope this World Health Summit will give the opportunity to identify partners for such a global health network. Thank you for your kind attention.
Thank you very much, Rachid, for this very concrete program. And if the summit could give birth to such a global health network, interregional network, I think this would be a very good idea. Now we are nearly at the end, but you have been so patient, so attentive. I would like to open the floor also for the audience. We have still 10 minutes. Is it okay? And I have a lot of questions, but I would renounce on my questions and would like to ask you if you would like to come in and to respond or to ask questions. It has been such a deep, rich information here from the MENA region. Please, could you present yourself? No, there was, okay. You should not have a conflict on this. Please, go ahead.
My name's George Patton. I'm from the University of Melbourne, Australia. In a sense, my question has already been asked. I'd just be really interested to hear the answer. Dr. Issa, I think you really made the case for investment beyond simply the health service systems, and clearly that's important. And I'd be really interested to hear from Dr. Barras. How is the World Bank actually... Yeah? Sorry, okay. Closer to my mouth. So, a question for Dr. Barras. How is the World Bank addressing the social determinants of health problems, given the rise in NCDs, given problems that are emerging like childhood, adolescent, young adult obesity?
Collect the questions. Please go ahead, and then we will...
Van Balling from Bibliomet Verlag here in Berlin. A question to the minister. You asked for help in the face of the refugees coming from Syria. What exactly would you expect us to do? To send money, or is it more you need more doctors or nurses, or maybe should we take some more of the refugees here in Germany or in the Western world? Thank you.
Thank you. And I give you the floor, directly the floor to you.
Thank you for your question. I think we faced a major problem with Syrian refugees, and my colleague mentioned that we faced 2 cases of poliomyelitis in south of Syria. Jordan forgot this problem for a long time. I think now we faced a major problem. We put a plan to vaccine all our population under teenagers and children with collaboration with WHO. But and this is the second program, the second vaccination in this year. I think we need help. Our socioeconomic status is not in good, is not healthy till now. I think we need both financially to be supported and even by another NGOs and medicines. We spend our medicines for, you can take in consideration, if Germany received 20 million people in a few months, what happened here? In Jordan, we received 1.5 million Syrians, and our populations are only 6 million. And it means that we are overstretched with this crisis. Thank you.
Thank you very much. I think it's good to put the figures and your challenges into a dimension. And you have said for Germany it would be 20 million of refugees if we take the proportion. And this is incredible. And I think it's very clear that we have to be aware of the situation, of the fact that civilian security or that part of the overall security of the region must be also civilian and social security. So, Enis, I would like to add one question. What is your capacity at the macroeconomic level in your discussions and dialogues with the governments to convince governments to invest into health and health systems, into visible success or progress of primary care?
Okay, thank you for these questions. Let me, okay, these microphones are good. Okay, let me start off by just adding one more word to His Excellency's comments on the refugee crisis. It is really huge. It is huge in Jordan. It is huge in Lebanon. We have just finished a socioeconomic assessment of the refugee crisis in Lebanon. According to our quantitative estimates, it actually reduced the GDP growth in the country by 2.9%. Okay, this is Lebanon. And it actually translates more or less to $3 billion. Increases on the expenditure side about 1.5 billion, if I remember correctly, and reduction on the revenue side by $1.1 billion because of lack of tourism, lack of many things. So these are really huge numbers for these countries, which have relatively small populations. As His Excellency said, Jordan is about 6 million. If you get 1.5 million people, some of them you can put them in refugee camps. The rest will be in the communities, in hosting communities. We have had a new project in Jordan, about $150 million to assist the Jordanian government, but it is definitely not enough. There should be also some donor money, etc., coming in. And it's the same case for Lebanon. During the United Nations General Assembly in September, there was a meeting about that, and also we followed that last week actually in the bank by another meeting of the donors to find out how we can help the country to cope with this crisis. These are huge crises. Now, coming to the macroeconomic situation, obviously, if you look at the macroeconomic situation in many of our countries, I would put the GCC countries aside, there has been a major reduction, shrinkage in the fiscal space for these countries because of the reduction in revenues. On one hand, these countries basically many of them rely on remittances, rely on tourism, relies on the revenues from the Suez Canal in the case of Egypt, for example, and all those things have gone down because of the economic crisis which came together with the Arab Spring, Arab awakening. Therefore, in a situation like this, it is very difficult to convince the governments to put more money into health. Right? Because the government revenues in most of our countries, government budgets, I should say, account about 25–30% of the GDP. Okay? So the GDP goes down, the revenues goes down, there is less money for the governments to put into health. And many of these countries traditionally were not putting enough money. If you go to Egypt, for example, if you look at the general government expenditures in Egypt, only 4% is for health. Now, I was actually in Egypt 2 weeks ago talking with the Minister of Finance, trying to find out whether they will have any space to increase the money for health. And it is a tough discussion because there are many competing demands. On the other hand, in a country like Egypt, if I may say so, for example, you have huge fuel and food subsidies, which are not targeted, which benefits everyone, whether you have a Mercedes or you have a small car or you have a diesel engine. And Jordan has already begun making big progress in this respect in terms of better targeting those subsidies, and Egypt is about to begin so. When they begin so, there will be more fiscal opening, talking about the macroeconomics, so that more money can be put into health and education. Coming to the question on social determinants. As you know, at the World Bank, we work across 19 different sectors. By definition, we work in a multi-sectoral way. Right? So many of the social determinants lie exogenous to the health sector, but with other sectors with which we cooperate. For example, even though I'm a sector manager for health nutrition population, but I'm also part of the group which manages human development, which includes social protection and education. Therefore, every time we have a new education project, whether it is early childhood or formal education, health is there through school health, early child education, nutrition, etc. on one hand. These are obviously social determinants. Education, it is the same. In addition to that, as you may know, because one of our objectives is to eliminate extreme poverty, we have many conditional or unconditional cash transfer programs in many of our countries. So these are means-tested programs that target really the poorest of the poor, and we give them money. Either it is conditional on them using education or health services, or unconditional simply as a support to their household budget, so that they can have more money for day-to-day living. So I think the social determinants are definitely there, sometimes through the health sector, but sometimes through other sectors as well. Thank you.
So thank you very much. We have reached the end of our session. I think a discussion on how partners could really strategically and coherently support would be another session. But we have learned a lot about the region from the different perspectives. Thank you very much to my panel colleagues for their speeches and presentations and for your contributions and input. And thank you very much for your for your attention and your presence and your interest in this area and in this issue. Thank you very much.